Thank you very much, Doctor. Before I move on and call the next speaker, ladies and gentlemen, I'd like to inform you that this year's theme for the conference is Incredible India. And as we talk about Incredible India, the first thing that comes to our mind, of course, is tourism. But this has nothing to do with tourism, and the reason why we've chosen this theme is because you are all contributing in your own small way, wherever you are in the country, for making India incredible. So we'd like to take this opportunity on behalf of APPI to thank you all, and making India incredible is on your shoulders. So I'm hoping that whatever you do take back from this conference will make a difference, and even a 1% change will make India even more incredible in healthcare. So thank you very much, and please give yourselves and the colleague next to you a big round of applause for making India this incredible. For our next session on managing thyroid in pregnancy, it gives me great pleasure to invite on stage Dr. Jaganathan Sickan, MD, MBA, Associate Director of Research, Medical Research Group, Medical Affairs, Abbott Diagnostics Division. Dr. Jaganathan Sickan read medicine at JIPMER Pondicherry, India, and graduated from the Madras University. He carries with him a total number of 13 years of clinical experience in the discipline of obstetrics and gynecology, where he did his residency. He completed his MBA with the Southern Cross University, Australia. He has published a few papers on thyroid disease in pregnancy and recently has been involved in the research and development of HS troponin I. Ladies and gentlemen, Dr. Jaganathan Sickan. And to felicitate him on stage, may I please invite on stage Dr. Madhukar Bhide. May I please have you on stage to felicitate Dr. Jaganathan Sickan, please. Ladies and gentlemen, your next session is going to be for 30 minutes as well. Please give a round of applause to Dr. Jaganathan Sickan.
Thank you. Good morning. Lovely Sunday, isn't it? Time already started. I'm going to talk to you about managing thyroid disease beyond TSH. We have to move on from what we have been thinking of depending on older assays. The early diagnosis and predictive and risk stratification is going to be there. So my agenda today is I'm going to talk to you about the thyroid peroxidase and antibody in pregnancy, the guidelines in clinical use, the prevalence of Tpo antibody, what is the usefulness of this antibody, excuse me, the reference ranges, methodology, and end up with summary. Looks familiar? Your guideline 34 in NACB. It is really there. It has been there for past 13 years. It clearly says Tpo antibody is used for the risk factor for autoimmune thyroid disease, is used for the diagnosis of autoimmune thyroid disease, risk factor for postpartum thyroiditis, risk factor for miscarriage and in vitro fertilization failure, risk factor for hypothyroidism in Down syndrome patients, risk factor for thyroid dysfunction in pregnancy. So here, you have a biomarker which is not only going to make diagnosis, it is going to give you the risk stratification in pregnancy. So when you look at the evolution of autoimmune thyroid disease, the presence of Tpo antibody is a pathological finding. It means that the patient might be having the disease right now or might have the possibility of developing the disease anytime in a lifetime. So it is very important for us to understand this value of this biomarker. Of people with elevated Tpo antibody and elevated TSH, only about 5% per year will develop clinical hypothyroidism. Now, that should make you wonder that there's about 95% of them walking quietly in the street with the possibility of having with the possibility of having thyroid disease. So only 5% of them will develop. So 95% of them are walking around. Now, looking at the prevalence of Tpo antibody among the Caucasians, Hispanics, Asians, the whites, look at us, the Asians. The positive for either Tpo antibody or TG antibodies is very, very high. So we are the best people to use this biomarker to identify our thyroid disease. You can easily pick up. Gone are the days where you have to wait for the thyroid disease to establish clinical symptoms to treat. With this biomarker, you're going to catch your thyroid at a subclinical stage, even before you develop clinical symptoms. So that is very, very good for you to understand. Your patients are not going to suffer and then have multiple unnecessary follow-ups. A study done, published in the year 2002, showing the prevalence of Tpo antibody in women is greater than men. And the prevalence of this woman is about 17% during your reproductive age group. So, why aren't we doing this biomarker when a woman gets pregnant? Tpo antibody and miscarriage. Pope and Glenor came up with this article. They said pregnancy loss can be caused by many factors. All of us know that. Approximately 1/3 of pregnancy end up in miscarriage. And most miscarriage occurs prior to the first missed menses, and approximately 10% of spontaneous abortions are clinically apparent. They went on to say both hypothyroidism and hyperthyroidism have long been associated with increased miscarriages. This association can usually be reversed by normalization of thyroid function by treating the underlying disease. Can you imagine if you were to diagnose a subclinical condition early in pregnancy, you're going to prevent the unnecessary miscarriages. Recently, Pope and Glenor reviewed 13 studies that examined the relationship between thyroid autoimmune and miscarriage. And what did they see? With the exception of 2 studies out of 13, they concurred to establish that thyroid autoimmune disorders without overt thyroid dysfunction is clearly associated with a significant increase of miscarriage rate. In these 11 studies that associated to thyroid autoimmune disease to increase miscarriages, the rate of increased miscarriage in the antibody positive group was 1.7 to 6.5 times higher than the antibody negative group. So, if you can pick up a Tpo antibody in a pregnant woman early in a pregnancy, her risk of having a miscarriage is 6.5 times. Very, very high. So look at the value of this biomarker. Further studies were done. These are the studies. All 13 studies clearly showed that Tpo antibody was present whenever the lady had miscarriage. Now, the thing is, we should not stop here. We are not olden pathologists where we just make the diagnosis and let the clinician manage. We should advise. Robert De Nigro did this. He not only used an assay to diagnose, he intervened by treating. So he divided his group of study of patients, pregnant women, into 3 groups. Those who had Tpo antibody positive were treated. Those who were Tpo antibody negative, and those who were Tpo antibody positive and not treated. And see what was the outcome. 58 subjects of his were Tpo antibody positive and did not have treatment, and they had a rate of 13.8% of miscarriage and 22% of premature delivery. Those who had Tpo antibody positive and were treated, the miscarriage dropped to 3.5%. And the premature delivery dropped to 7.3%. But what about those who did not have Tpo antibody? No difference between the positive that was treated, and the negative, 2.4%, 8.2%. Huge reduction by intervening and advising this patient needs to be treated. From 22% of premature delivery to 8.2%. That's wonderful. Now, when we look at the outcomes, this is how it looks when you put it in a graph form. Numbers might not really get us excited. Look at this. Tpo antibody positive and treated, Tpo antibody negative, and look at the Tpo antibody positive and not treated. Huge difference. Postpartum thyroiditis. Not many of us have heard about this, but it has been there for the longest time. It's a disease that is very common, caused by autoimmune inflammation of the thyroid gland. Very simple. Every organ in the body during pregnancy enlarges. Some of them undergo inflammation. And why we have not been bothered is pregnancy is only 9 months. And we are overcome by the joy of having a baby. We tend to forget the woman. Postpartum thyroiditis occurs in the first year following delivery. And in a recent article reviewed by Stegnora and Green, they reported the mean prevalence of postpartum thyroiditis to be about 7.5%. Big numbers, my friends. 7.5%. Women who have had an initial episode of postpartum thyroiditis have a 70% chance of recurrence in the next pregnancy, which might have gone silent in the first pregnancy. Long-term follow-up of women with postpartum thyroiditis have shown that 25% of them will eventually have permanent hypothyroidism. Numbers are big. When we looked at these numbers, and I really got very excited and worried. Postpartum thyroiditis is very closely associated with the presence of Tpo antibody. If the Tpo antibody is present in the first trimester, that particular lady has a risk of 50% of having postpartum thyroiditis. And if she has it in the third trimester, the risk becomes 80%. A part of a larger study, Noor and group studied the relationship of Tpo antibodies with postpartum thyroiditis. He went on to say that Tpo antibody is a good predictor of postpartum thyroiditis. We are moving away from diagnosis to predict. This is how laboratory medicine should move. I am not telling you what you're having. I can tell you what you will be having. We must move to that stage. Antibody levels were high in women with biphasic causes of postpartum thyroiditis and with hypothyroidism only, and were much lower in the hyperthyroidism only and euthyroid groups. The numbers were huge. Tpo antibody concentration in early pregnancy and the risk of developing postpartum thyroiditis. Higher not only Tpo antibody is going to be qualitative, it's going to be quantitative value for you. If the value is higher, higher is the risk. So you are going to benefit by not only making a diagnosis, by not only making a predictive diagnosis, you're going to quantify what is her risk of having postpartum thyroiditis. Next, let's look at the reference ranges. TSH. I put this up because there have been a lot of questions about TSH reference ranges in pregnancy. We need to establish one for pregnant women. The guideline 22 from NACB says TSH reference intervals should be established from 95% confidence limits of log transform values of at least 120 rigorously screened normal euthyroid volunteers. You have to establish in your lab. No personal or family history of thyroid dysfunction, no visible or palpable goiter, no medication, no thyroid autoantibodies should be present. So from 120 with negative Tpo antibody, no family history of thyroid disease, no palpable goiter, you should establish your reference value. So what is the normal TSH value? The definition of what represents a normal TSH value has changed in the last few years. Some of us take 0.3 to 4, or 0.4 to 4. Some of us take 0.5 to 5. But we know if anything is between 0.4 to 4, whatever value we take, it's normal. And we also have realized that 95% of healthy euthyroids, the TSH level is below 2.5. This was a study that was done, and they said, okay, majority of us have thyroid TSH levels below 2.5. And they said, if it's above 2 and you have Tpo antibody positive, you have an increased risk of having hyperthyroidism or hypothyroidism. Hypothyroidism. So we know the subnormal TSH can be seen in about 20% of normal pregnancy. The trimester-specific ranges needed to be established for pregnant. You cannot follow the normal one. Those who have levels above 2 and Tpo antibody positive have a high risk, and those who are above 10 are clearly having hypothyroidism. The NACB guideline 27 says serum TSH measurement is the most diagnostically sensitive test for detecting mild, that is subclinical hypothyroidism, or overt primary hypo or hyperthyroidism in ambulatory patient. The majority of healthy euthyroid subjects have a serum TSH concentration below 2.5. Ambulatory patients with TSH above 2.5, when confirmed by a repeat TSH measurement made after 3 to 4 weeks, may be in early stages of thyroid failure, especially if the Tpo antibody is detected. It is in your guidelines. You need to bring down your TSH level to 2.5 when you do a Tpo antibody positive. It is there. So we need to move beyond a diagnostic TSH to a predictive diagnosis. Here we come. Let's look at this. Normal values. Any value of TSH below 0.4, if that free T4 is normal, we'll make a diagnosis of, we'll do a free T3. If the free T3 is increased, we make a diagnosis of early hypothyroid. If it's normal, then we put them on thyroid replacement. Values between 0.4 to 4, they are normal. Values above 4, then we do a free T4. If it's normal, we say a subclinical hypothyroidism. If it's increased, we think it is thyroid resistant or pituitary tumor. If it's decreased, then we make a diagnosis of hypothyroid, clinical hypothyroid. Very clear. This is what we follow. The numbers might change. 0.4 to 4 might be 0.5 to 5 and so on. But everything changes when you introduce Tpo antibody. Your upper limit of TSH becomes 2.5. So you start treating, especially in pregnancy. You know why it's so important to pick up thyroid disorders in mothers in pregnancy very early? I shared this in a work group that we had yesterday. In the first 3 months of pregnancy, the fetus doesn't have a thyroid gland. It solely depends on the thyroid hormones from the mother. And we know thyroid hormones are very important for the mental and motor development. So if you can pick up a slight change in thyroid hormones in the mother very early and treat it, you're going to save the baby. and later save the mother. I'm not saying save life. You're going to have better kids in the world. So that's why it's so important to use this Tpo antibody as a predictive marker along with TSH and treat this group of people. And especially in pregnancy. It doesn't only help you to pick up hypo. It helps you to pick up subclinical thyroid conditions. Simple. Patient presents to you with low TSH. When you do a Tpo antibody, we all know in the first trimester, the TSH level is very low. We agree, right? It's because of the doubling effect of beta-HCG. The brain identifies similar structure, beta-HCG, TSH. Oh, beta-HCG is going up, so something similar to TSH is going up, I'll stop the production of TSH. So TSH is very low in the first trimester, which is normal. But we are not so sure that low TSH is not because of a disease. So how do we prove this? We do a Tpo antibody. If the Tpo antibody is positive, something is wrong with the mother. If the Tpo antibody is negative, nothing is wrong. This low TSH is because of the first trimester effect. When we look at the implication of Tpo in the setting of reference ranges, it's good. Our life is good when we can separate between no disease and disease. But when you do a Tpo antibody, look at the subclinical state. Excuse me. You are picking up that group, the niche group, which is going to save a lot of headaches for the parents after the child is born. Very important, which assay you're using. It's likely the isoform that matters. You don't want to have an assay which has huge variation. This study was done by Rollins. Rollins' paper was the best paper to tell us. When you are using thyroid assay, you need to pick up an assay which doesn't vary too much. The variation should be very close. The Chinese have inflicted us. Okay, now, I just wanted to share with you, this is one project we did with Dr. Liu in China, establishing TSH levels in pregnancy. Just wanted to show you that the TSH values vary in all 3 trimesters. And we did it on all the platforms. Another study to show a head-on comparison between Abbott's and Roche. You need to look at these numbers, the 97.5 percentile. How good are they? The numbers itself proves to you. In summary, Tpo antibody is an early predictive marker. You can predict whether the lady is going to have miscarriage because if a lady has a Tpo antibody early in a pregnancy, she has a 6.5 times higher risk of having an abortion. It is an early predictor as far as postpartum thyroiditis is concerned. If a pregnant mother has Tpo antibody in the first trimester, her risk of having postpartum thyroiditis is 50%. If she has thyroid antibody in the third trimester, her risk becomes 80%. Now, let me give you more numbers to remember. If that mother is having type 1 diabetes, Tpo antibody is present, her risk of having postpartum thyroiditis becomes 3-fold. Meaning, presence of Tpo antibody in first trimester, mother is having type 1 diabetes, her risk of having postpartum thyroiditis becomes 150%. If she has it in the third trimester, the risk becomes 240%. Big, big numbers. Thyroid hormone reference ranges should be established in pregnancy. You cannot follow normal reference ranges in pregnancy. You can have, a lot of papers are out. Low TSH values in early pregnancy, we know it's because of the beta-SG effect. Every pregnant mother will have low TSH in the first trimester. How to prove that this low TSH is normal? Do a Tpo antibody. Expected reference ranges should have values in the low values in first trimester, subclinical, and push this forward. Do all platforms offer the same specificity and sensitivity? That's for you to answer. Because you require highly specific and sensitive TSH in pregnancy. Very, very specific. You cannot use the run-of-the-mill assay and say, oh, my TSH value is 5, or my TSH. You need to look at Rowland's paper. That's the paper we are using at gold standard. You require full range of thyroid testing. You require thyroid antibody methods that recognizes different epitopes in the heterogeneous antibody population. I would suggest Tpo antibody compared to any other antibody because when you take thyroid autoimmune disease, Tpo antibody picks up about 95% of them, saved by your antibody to be used. Before I leave you, I would like to share an algorithm which I shared with the workshop yesterday. It's a very simple algorithm for pregnant women. If you have anyone who's planning to get pregnant or is pregnant, simply do TSH and Tpo antibody. If a TSH is normal and Tpo antibody is negative, leave her alone. But if a Tpo antibody is positive and a TSH level is below 2, I didn't want to put the number 2.5 because we are very good with single digit. When you say 2.5, we tend to forget. 2, anything below 2, don't treat her. See her back in 6 and 9 months. You know why? Because her Tpo antibody is positive. So you want to see whether she's going to have the Tpo antibody in the 3rd trimester. And then manage her after delivery for postpartum thyroiditis. And the third one is very simple. If a Tpo antibody is positive and a TSH is above 2, do a free T4 and treat her. The free T4 will definitely be normal, but you need something as an evidence to make a diagnosis of subclinical hypothyroidism. And the final one is, when the TSH level is above 4, regardless of the Tpo antibody status, do a free T4 ultrasound to rule out any type of cancer, treat her with levothyroxine, monitor postpartum for postpartum thyroiditis. We fail to realize that 30% of our women undergo depression after delivery. Our women are the best people in the world because they don't show their depression. They only show it to one person, to their husband. Okay? So let's get this thing away. Why do you need to make them go through? They already went through hardship in 9 months. It's very simple. Like I shared this with the group yesterday. Professor Sumpaiko, who led the study in South Asia for prevalence of Tpo antibody and treating pregnant women in subclinical condition, said treating thyroid disease, hypothyroidism in pregnancy is like adding salt to your gravy. You just need a little bit. The gravy will taste better. So does life becomes better after you identify this condition. Thank you very much.